Okay, so we'll do EEG first and then we'll do a bit of psychopathology. Is that all right? Or you guys want to do the psychopathology first?
So EEG first is fine.
Okay, perfect. EEG is, just to give you a short background to it, EEG is something that if you're preparing for your MD, EEG is definitely something which is very important. As far as your paper A is concerned, they have a short set of questions which they tend to ask as far as the EEG is concerned. We'll definitely cover that. EEG is more of a paper B question though. So eventually you will have to go through EEG one way or the other. And the more clearer you are about the concept, the better it is. Um, but wouldn't worry too much about the EEG in the paper A, to be honest. Okay. Shall we start? We have about five people.
Yes, sir.
The screen is visible.
Yes, sir.
We need to do something about people keeping popping in. Okay, so we'll do the EEG first. Now we'll wait for 4-5 people and then admit all of them.
Maybe you can disable waiting room.
Disable the
Waiting room.
how do I do that? Meeting settings.
Yes, sir.
Okay. Is it all right now?
Yes, sir.
Yes, sir.
Okay. So, so let's get started with the basics. EEG and MEG. So, what is the basic principle behind how an EEG works? Can anyone tell me? Think of this as a basic electrode, right? And you have a anode and you have a cathode. So the way the EEG works essentially is that it measures the electrical difference uh, between certain areas of the brain. And what it does is essentially it amplifies the electric charge of this difference between the two electrodes. And because of that, you will be able to see a clearer picture of the electrical activity of the brain. It is it is an electrical neuroimaging method, and it essentially has two electrodes. Usually, metal electrodes are used, and there are two types of EEGs. Usually, you either have the 24 electrode system or you either have the 32 electrode system, and usually it is the 24 electrode system which is most commonly used. Can anyone name the pattern which is the most commonly used system to arrange the electrodes? The 10-20 pattern?
Take it for her.
Sorry?
Sorry. I'm so sorry.
Has anyone heard about this pattern, the 10-10-20 pattern? So this name is essentially given because of the amount of distance between each electrode. So the percentage wise, it is either 10% or 20%. Um, all right. So if this is the skull and we are looking at it from the top, right? Then essentially it is divided into F, FP, C, T, and O. F stands for frontal, FP for frontoparietal, C for central, T for temporal, and O for occipital. Then remember this one thing is that the right side is the even number, or the left side is the even number?
Right is even.
Right. Left is odd. Okay. All right. So this is how the electrodes are placed usually. You have the F0 here, right? So you will have your F1 here and your F2 here. You will have your FP here and essentially have your FP5, FP7, F6, F8. So like the distance between, okay, I'll tell you that afterwards. You have your C here, right? And you have your C3 and C5. And have your C4, C6. Then you have your T, T5, T7, T4. Sorry, T6, T8. And finally, you have your occipital here. You have 3 and O2. So don't ask me how and why we have numbered these, because I don't know exactly why this is not 3 and this is 5. I don't know the logic behind that. If anyone does, then please explain. Does anyone know the logic behind why this is not 3 and why this is 5? Okay, all right. So thankfully, everyone is as confused as I am regarding this. So this is essentially a 10% gap, right? And this gap is a 20% gap. Similarly, this gap is again a 20% gap. Similarly, these are 20% gaps, 20% gaps. And this is again a 10% gap. So you can see that the electrodes are placed kind of either at a distance of 10% or at a distance of 20%. And that's why this is known as the 10-20 system. So when you see an EEG in your clinical practice on the monitor screen, has anyone seen an EEG? Anyone?
So seen or
Okay.
read?
Seen is
Yeah,
also
yeah.
all right.
Yeah, yeah, seen.
Right. So there are usually two software systems, okay, as far as the EEG concerned. If this is your computer screen, your computer monitor, then um, one of the softwares, what it does is it essentially divides your entire screen into two parts. So on the upper part, there will be either all the odd numbers, and on the lower part, you'll have all the even numbers. So what it does is it essentially, and you'll see that if this is say mm, FP6 to FP8, right? And then you'll have another lead here. So what this does is essentially it's not an individual leads reading, but what you're reading is essentially the gap or the change between these two leads. So you're using lead this as a reference point and lead this as a reference point, and then you're reading what differences are there in the electrical activities at specifically at these leads. So if you see any inconsistency, you see a major increase in the amplitude, or if you see a major increase in the frequency, uh, essentially you'll have vertical lines on the EEG, and these lines essentially have denote a gap of 1 second. So like in your ECG, each small box, if you remember, represents a 40 millisecond gap, and the large box represents a 20 millisecond. Okay. Um, shall I mute the other ones? Okay. So, and the large boxes represent a 200 millisecond gap. Similarly, the gap between each vertical line essentially represents, I think it's either 0.5 seconds or is it 1 second? Does anyone remember the gap is 0.5 seconds or 1 second? Most likely it is 1 second, but I'll correct myself in the group if I'm wrong by any chance. So that's how you can count the number of waves, and you can tell that if it is a alpha wave or a beta wave or a delta wave or a theta wave. So this is how basically how the EEG works and how it appears on your screens. And if it is a problem in, if you notice an inconsistency in the odd numbers, then essentially you're having a problem in the left part of your brain. And if you notice an inconsistency in the right part of in the lower part of your screen or in the even numbers, it's a problem in the right part of your brain. um, so what are the common waves of the EEG? Can anyone tell me?
Alpha.
Okay, so tell me the wavelengths of each of these waves, the frequency, sorry.
Delta is less than 4.
Delta is less than 4. Okay. Theta is?
Theta from 4
Delta
to 8.
from 4 to 8.
Okay. Then alpha would be?
From
Alpha
8 to
from
13.
8.
And beta would be?
More than 13.
It's usually 13 to 30. There are also other waves which are beyond 30. So 30 to 200 is also called something. I don't exactly remember. But these are the
Sigma.
basic waves that, sorry?
Sigma.
Yeah, sigma. That's 30 to 200. But these are the ones which are essentially the most responsible, or the ones that you really do need to remember. So in the NREM sleep, what kind of waves would you usually have? The NREM sleep is essentially your slow wave sleep, right? And your REM sleep is a comparatively fast wave sleep. And specifically within the NREM also, in the first stage, you will essentially have theta waves. In the second wave, you will have K complexes and sleep spindles. So this is a question that they will ask in your paper A. It's a favorite one. K complex and sleep spindles are found in which phase of sleep, and they'll give you all these options. And in the third and fourth, again, you will have mostly delta waves. Is that all right so far?
Yes, sir.
And during your REM sleep, it will essentially be an interplay between your theta and alpha waves. And so when your eyes are open and you're focusing on something, or your mind is actively working, it's essentially the beta waves which work. And when your eyes are closed but you're still awake, it's essentially your alpha waves predominantly. And they say that when you're meditating at a very high level but you're still awake, so that again goes somewhere between your theta and your alpha waves. So these are basic outlines of an EEG. You can delve into much more details if you want. um, I wouldn't go much into details as far as the paper is concerned. I think this much is, as far as the normal EEG is concerned, this is what is essential. Then the pathological EEG findings that they usually ask. So write these down, put them up on your blackboard, or memorize them, because these are the following ones are just rote memory essentially. There's not uh, a lot of logic to it, but you still do need to memorize all of these. So what kind of an EEG finding do you find in Creutzfeldt-Jakob disease? And the answer would be, you'll find typical biphasic and triphasic wave pattern. Okay. In Huntington, you will find low voltage, specifically no alpha. In So this is a good question that they usually ask, is it's either delirium or delirium tremens. Okay. And in delirium, you essentially have slow wave. You have diffuse slowing. And by diffuse, they mean that it's not particularly in a particular focal region, it's all over the entire computer screen. So it's diffuse slowing in the delirium. And you essentially have more of delta and theta waves. Whereas in delirium tremens, it's a hyperactive fast race. Right? Again, in dementia, you again have slow waves. These can be focal. So if it is a frontotemporal dementia, the slow waves will be specifically um, localized to that area. If it is Alzheimer's, you'll see that they are localized initially towards specifically the temporal lobe. Um, your generalized epilepsy, or your GTCS, would essentially have 25 to 30 hertz spike and wave pattern. And your absence seizures would essentially, I think, have a 3 hertz pattern, and that would also be spike and wave, but it would be a 3 hertz pattern that you would essentially have in your absent seizure. And if it is a complete seizure, then again it will be just like GTCS. It will not be focal. It will be throughout the brain. So initially, the epilepsies were classified based on the symptomatology or the clinical aspect. So you would have generalized tonic-clonic seizure or partial seizure. Now the new classification, if you all have gone through, it's essentially seizures which are focal in origin, seizures which are generalized in origin, seizures which are initially focal and then generalized. So rather than it being a symptomatic or a clinical classification of the kind of seizures that a person has, it has shifted now. I think it was in 2017 that they brought out the new classification. It has essentially shifted to where the seizures are originating and how they are spreading eventually. Um, in partial epilepsy, you have focal spikes in the seizure activity, and in myoclonic you would have generalized spike in wave activity. In encephalopathy, you would have a generalized slowing again. And in normal aging also, you would have a slowing. All right.
Sir, this is Varsha. I have a doubt, sir.
Yeah.
Sir, how do we differentiate between encephalopathy and delirium EEG, sir?
Yeah. So these are just EEGs that you have so far. But you also, when you're in the real life, you don't just make a decision in real life based on the EEG. If you've read any EEGs, you would see that even in a clear-cut GTCS EEG, they will make sure that they're on the safer side, and they'll write for themselves that kindly coordinate clinically, wouldn't they? So
Yes, sir.
these are just broad findings that you would have. But EEG is not something which, on the basis of which you can say that the patient is suffering from encephalopathy just on the basis of an EEG. You would want to do the CRPs, you would want to do some brain imaging, you would want to take a clinical history of the patient, and that's how EEG can help you with the diagnosis, definitely. Because if a patient presents with, say, mm, manic symptoms, right? And in particularly in mania, so if it is a non-organic mania, then you would have an increase in the alpha waves. But if it is a mania which is uh, whose origin lies essentially in encephalopathy, then you would have generalized slowing. And um, so you do need to essentially um, take the clinical and blood tests and everything into consideration. That's when you will essentially reach a diagnosis. um, I hope that helps, because that's all I can say as far as the EGs are concerned. Is that all right?
Yes, sir. Thank you.
Yeah. Similarly with the benzodiazepines, so does anyone remember what benzodiazepines do to sleep?
Short.
Why the benzodiazepine sleep is not very satisfactory in nature?
REM duration will increase.
Will decrease or increase?
Increase.
Will decrease. REM. So think of REM as the kind of sleep that gives you satisfaction, right? And the
So yeah.
benzodiazepine sleep will give you good NREM sleep, but it won't really give you a lot of REM sleep.
Yeah.
So in benzodiazepines, so if a person is really anxious, then the way you can visualize it in your head is that if a person is really anxious or is really manic, then there would be spots of depolarization all over the brain, wouldn't be?
Hmm.
So obviously that person would produce a lot of electrical activity. So if you take a benzodiazepine, it will increase the alpha waves. because it will reduce the amount of beta waves and increase the alpha waves, but it won't really increase a lot of the delta waves as such. So it will not be a very sound sleep, but it will be a calmer sleep as compared to what that person was having during a completely pathological frame of mind. So let's do a quick revision of the EEG so far. What kind of finding do we get in delirium tremens?
Fast, hyperactive.
Hyperactive, and in normal delirium,
Diffuse slowing.
Generalized slowing.
diffuse slowing. Good. And what about Creutzfeldt-Jakob disease?
Biphasic and triphasic.
Right. And what will be the frequency in absent seizures?
3 hertz.
Spike and wave.
Spike and wave. Yeah. And what about GTCS?
25 to 30.
All right. Good. And are we left with anyone?
Huntington.
What about sorry?
Huntington's.
Yeah. What about Huntington's?
No alpha waves.
No alpha waves, and they would be generalized fast waves or slow waves. Slow waves, low voltage. All right.
Yes, sir.
I think that's about the basic idea of the EEG. Yeah. What are the techniques that we usually use in an EEG to make sure that we get the pathology?
We cause the patient to get seizures by
Yeah.
throwing light,
Hyperventilation.
blinking light.
Hyperventilation. So when we give light, what is it known as? Photic stimuli. So we use hyperventilation, photic stimuli, and there is one more. Remember, we instruct the patient's mom, if it's a child patient, then we instruct the patient's mom to not allow the child to sleep.
Sleep deprivation.
Yeah, exactly. So these are the 3 commonly used techniques to make sure that we are able to precipitate the main pathology that the person is suffering from. Just an interesting we are to make this rather boring topic interesting is, what is an MEG and how does it differ from an EEG? Anyone?
Magnetoencephalogram.
And how does it differ from an EEG?
I am guessing like there we are measuring electrical waves and here obviously not.
So essentially the EEG is sensitive to both. It's sensitive to radial and tangential electrical waves. And that's why it produces a lot of clutter. So it's really, it has a lot of impedance. It has a lot of spherical volume which it needs to cover, whereas the MEG specifically detects only the tangential currents, and it does not really. Sorry.
I didn't get the full form actually.
Magnetoencephalogram. So it focuses essentially only on the tangential current, and that's why it gives us a comparatively clearer picture. Just to put things into perspective, initially we used to it was all about structural brain imaging. So if you even if you say it's a CT scan, or if you say it's an MRI, these are essentially structural brain scans. Whereas EEG, you can say, is the first functional brain scan. And can anyone tell me a couple of more functional brain scans which are comparatively recent?
Functional MRI.
Your fMRI, your PET scan. What is the full form of PET scan?
Electron emission tomography.
And what about SPECT scan?
Uh,
Single photon emission computerized tomography. And what about the DAT scan? It's something related to dopamine receptors. I also don't know the full form, but it's essentially the test of confirmatory test for Lewy body dementia. So you could say that EEG was essentially the first functional brain scan in a way, and and the way it is used is it is used in ECTs. So the different uses of EEG, you can say that it's used in ECTs to check about the duration of the seizure that the patient has had, because you're already giving the patient pentothal, and you're already giving the patient a muscle relaxant. So just clinically looking at the seizure won't really give you the right idea about the duration of seizure, would it? So you use an ECT. Most of the ECT machines nowadays come with EEG monitoring, so you're able to see the seizures. And there are three phases. So there's an initial phase where there is slowing of waves. Then there is a seizure phase where there is a fast-paced wave, and then after that there is again a slowing, and then the electrical activity returns back to normal. So these are technically the three phases that you see when you hook up an EEG monitor along with your ECT. It's also used in polysomnography. Right? And it's also used to monitor normal sleep. And one of the most vibrant, or one of the most uh, newest uses of EEG, you can say, is that it's a tool to confirm death. So if you're able to recall the previous definition of death that we used to study during our undergraduate days in our forensic textbooks, it was the stoppage of the three main systems of the body which make the body work, right? So it's essentially the respiratory system, cardiovascular system, and the central nervous system. Now you have ventilators for the respiratory system, you have artificial pacemakers, and a lot of different tools to make sure that that the heart keeps pumping blood, essentially. But you don't have a tool to restart the brain. So the EEG is essentially used to confirm death. So if you get a flat line on your EEG, then you can say that this patient is now essentially not surviving anymore. And so that's why they want to take an EEG at least 12 hours apart, and that is used to confirm death. So this is an interesting trivia, or um, something related to EEG. I think that's all as far as the paper A is concerned. This is also a bit too much for the paper A. These things they'll essentially ask you a bit in the paper B. They might ask delirium and delirium tremens and all in the first paper. They might ask you a little bit about the 10-20 system. This they'll definitely ask, the NREM and the REM and the sleep phases. They'll ask you what is usually the frequency of the beta wave, what is usually the frequency of the alpha wave. These are essentially more paper-ish questions than the pathology. They would ask you the pathology in the paper B more often. Is there anything else in the EEG that you would want to discuss? All right. should we move on to discuss a bit of psychopathology?
Yes, sir.
Okay, let's take a 5-minute break. I'll send you the new link. I think it's almost more than 30 minutes that we've been on this call, so it'll get cut soon. Take a 5-minute break, drink some water, get some coffee, because this is really a boring topic, EEG. Psychopathology is interesting, so we'll get to psychopathology, and I'm sure it would be fun. Okay, I'll send you a new link in about 5 minutes.
Okay, sir.